Now, if we're looking for lesions such as hepatocellular carcinoma, as you will know from CT and MR imaging, we're looking very much for the vascular characteristics of these particular lesions. As you know, a hepatocellular carcinoma will tend to show a strong enhancement in the arterial phase with early washout in the portal venous phase. And this is due to a fundamental property of the liver with its dual arterial and portal venous blood supply, and the transformation of normal liver tissue to tumour tissue involves the progressive switching of blood supply into the pure arterial phase and away from portal venous supply. And this is progressive. As we go through from normal liver to a regenerative nodule, we have the normal balance between arterial and portal venous supply, with perhaps 70% of the normal liver tissue being supplied from the portal venous circuit. If we go through dysplastic nodules, we gradually introduce an abnormal arterial supply, and as we go through progressively more malignant lesions from well-differentiated to poorly differentiated HCC, in the end this transformation is complete, and the poorly differentiated HCC will derive its entire blood supply from an abnormal arterial circuit and almost none from the portal circuit. This property was used extensively in the early days of CT, where we were doing CT angiography using direct hepatic artery injection of contrast, and then portal venous imaging using injection of the superior mesenteric artery to fill the portal circuit after circulation through the intestines. And it was shown very elegantly back then that these lesions, even quite small lesions, if they were truly malignant, derived almost their entire blood supply from the hepatic arterial circuit with minimal supply from the portal venous circuit. This involved arterial cannulation when transferred to the CT scanner and rather fell out of favour, and we can get almost as much information today with modern CT scanners from a rapid intravenous bolus, although there is some blurring between the two, the arterial and portal venous phases, but with practice diagnostically we can do almost as well. Interestingly, the CT arterial portography is coming back into fashion, where particularly interventional radiologists in the Far East are working with hybrid systems, combined angiography and CT systems, particularly where they're performing super selective embolization and chemoembolization. So this technique hasn't gone entirely out of fashion. It is coming back quite well. Now, that property can be visualized using ultrasound contrast agents almost as well. Here's an example of a large 4 centimeter HCC within the right lobe of the liver, visualized by conventional B-mode imaging. Here is the arterial phase of an ultrasound contrast study given by intravenous injection. We can see the feeding vessel here into the tumor with large vessels in the center of the tumor and a very strong arterial phase enhancement with minimal enhancement of the lung parenchyma around. Fairly characteristic features of an HCC. And here we can see the same sequence again with the conventional B-mode image before contrast injection, strong arterial phase enhancement, here with some central necrosis, and here you can see what is called early washout, where in the portal venous phase, at about 60 seconds after the intravenous injection, we have relatively poor enhancement of the tumor with strong enhancement of the surrounding normal liver parenchyma. According to the criteria of the European Association for Study of the Liver, visualization of this classic pattern is sufficient to diagnose a hepatocellular carcinoma without the need for biopsy. We can also use the same techniques for diagnosis of very small metastases. This is a colorectal liver metastasis. It's about 1 centimeter in diameter, here in the portal venous phase, and we can see good enhancement of the normal liver parenchyma around with very high contrast ratios between the tumour and the surrounding normal liver. This is the corresponding CT scan, where we can see this small tumour which has an enhancing halo. We're more in the arterial phase here than in the portal venous phase, but you see exactly the same temporal characteristics with contrast ultrasound as you do with CT. We can also have some interesting observations in chronic liver disease. Here is a patient with cirrhosis with nodule formation that on the basic B mode image we can see a rather diffuse nodular pattern. After administration of contrast and viewing in the delayed phase, we can see that this nodular pattern has been enhanced, and we can see much more clearly the individual nodules, their size and size variation that go up to make the standard cirrhotic pattern. So we can use this in diffuse liver disease not only for detecting malignant focal lesions, but also for enhancing the pattern of nodule formation. Some people have used contrast to look at physiological parameters, and one of these is the mean hepatic transit time, where one is looking at the difference in time between the arrival of contrast in the hepatic artery and portal vein to the arrival of contrast in the hepatic veins. And it's been known for many years that this is shortened in cirrhosis, where patients have a hyperdynamic circulation. This actually compares two different contrast agents, but it does show that it is possible to obtain physiological information, if that's what you're interested in, by using contrast agents. We have used high MI imaging using the first generation contrast agent Levervist for studying other types of tumour within the liver, particularly Klatskin tumours or hilar cholangiocarcinomas, which can be extremely difficult to see by conventional ultrasound, by CT or MRI scanning. This is using the delayed high power high mechanical index technique, and you can see here an abnormal texture in the central portion of the liver on the pre-contrast scan, but here looking in the delayed phase after contrast, we can very clearly demonstrate the full extent of this malignant process within the central part of the liver. Here's another example showing very clear delineation not only of the full extent of the tumour at the hilum of the liver, but looking at the very sharp boundary that this tumour presents, we can see whether or not there is direct invasion into the surrounding liver parenchyma or merely a simple mass effect. You can get the same information occasionally from CT scanning. Here's an example of a nice 3D study where we have particularly clear visualization of the tumour mass at the hilum of the liver, but this is unusual for CT, and what we've found in our studies of this process that the ultrasound contrast technique is as effective as the best technique we otherwise have, which is MRI, and significantly better than CT scanning, demonstrating the presence of a mass, demonstrating the size of a mass, and demonstrating the extent of invasion into the surrounding liver parenchyma. Very often the clearest images are obtained by ultrasound contrast rather than by CT or MRI, though each have their own particular advantages.